Hello, my name is Chandra King. I'm a DNP FNP student at Idaho State University, and this is my presentation on fibromyalgia treatment and reduced opioid use. I'd like to start out by talking a little bit about fibromyalgia. Patients with fibromyalgia may be more sensitive to pain with abnormal pain perception processing and have widespread chronic pain with additional somatic symptoms, including fatigue, sleep, mood and cognitive disturbances, headaches, bowel and bladder issues, and often emotional or mental distress. Despite professional organization standards and evidence of ineffectiveness, opioid analgesics continue to be a mainstay treatment option for patients with fibromyalgia pain. However, according to guidelines and research, non pharmacologic treatments have improved fibromyalgia pain and related symptoms. Roughly 1.1 to 5.4% of the adult population suffers from fibromyalgia. Although the American College of Rheumatology's 2016 diagnostic guidelines give clearer, practical criteria for the clinical diagnosis of fibromyalgia, it still takes an average of 2 years to diagnose because of the inconsistency of patient presentation and a vast range of symptoms. Fibromyalgia has a financial impact of nearly $4,000 annually, with additional loss related to productivity at home and in the workforce. In recent years, opioids have been routinely utilized to alleviate fibromyalgia pain, which increases opioid addiction risk. At least 11% of patients with fibromyalgia uses opioids regularly. Opioid addiction is a significant public health issue in the United States, and despite opioid ineffectiveness in treating patients with fibromyalgia, opioids are frequently recommended. Tolerance to opioids builds with time, requiring greater dosage to relieve pain. The opioid pandemic is worsening, and the risk of unintentional overdose is increasing. Opioids contributed to approximately 46,802 deaths in 2018. In 2017, the cost of opioid use disorder was roughly $471 billion. Fatal opioid overdose was about $550 billion, and the economic cost of the U.S. opioid epidemic was estimated up at $1,021 billion. The 2016 revision of the 2010-2011 fibromyalgia criteria combines physician and questionnaire criteria, reduces misclassification of regional pain disorders, and eliminates the previously confusing recommendation regarding diagnostic exclusions. The 2010-2011 guidelines diagnosed adults when they met all of the following criteria. 1. Widespread pain index or WPI was greater than or equal to 7, and symptom severity scale or SSS score was greater than or equal to 5. Or the WPI was 3 to 6 and the SSS score was greater than or equal to 9. 2. Generalized pain comprised in 19 areas of the body, and the patient has to show where the pain was in the past week, scoring 1 point for each painful area. 3. Symptoms have to be present at a similar level for at least 3 months. 4. There is no other diagnosis that could explain the pain. The revision makes the following changes. 1. Changes criterion 1 to WPI greater than or equal to 7 and SSS score greater than or equal to 5, or the WPI is between 4 to 6 and the SSS score is greater than or equal to 9. The WPI minimum must be greater than or equal to 4 instead of the previous greater than or equal to 3. 2. Adds a generalized pain criterion, that is defined as pain in at least 4 of 5 regions: left upper, left lower, right lower, or axial. In this definition, jaw, chest, and abdominal pain are not evaluated as part of the generalized pain definition. 3. Standardizes and makes 2010 and 2011 criterion wording the same. Symptoms have been generally present for at least 3 months. 4. Removes the exclusion regarding disorders that could sufficiently explain the pain, and adds the following text. A diagnosis of fibromyalgia is valid irrespective of other diagnoses. A diagnosis of fibromyalgia does not exclude the presence of other clinically important illnesses. 5. Adds the fibromyalgia symptom or FS or polysymptomatic distress PSD scale as a full component of the fibromyalgia criteria. 6. creates one set of criteria, the 2016, instead of having separate physician, which was in 2010, and patient, which was in 2011 criteria, by replacing the physician estimate of somatic symptom burden with ascertainment of the presence of headaches, pain or cramps in lower abdomen, and depression during the previous 6 months. 4 guidelines are used when deciding the course of treatment for patients with fibromyalgia: the European League Against Rheumatism, or EULAR, the Canadian Pain Society and Canadian Rheumatology Association, the Association of the Scientific Medical Societies in Germany, and the Israeli Rheumatology Association. The two most recently updated, known, and used are the EULAR and the Canadian Pain Society and Canadian Rheumatology Association. The EULAR was updated in 2016 and the Canadian guidelines were updated in 2012. According to those recommendations, patients should be managed in primary care, with specialists consulted in case of unexpected symptoms that might point to a different diagnosis. Hundreds of fibromyalgia therapy options were found and reviewed by the EULAR guidelines, which also determined their effectiveness in evidence-based use. The non-pharmacologic treatments assessed include physical exercises like aerobic and strengthening, mindful therapies like cognitive behavioral therapy, guided imagery, hypnotherapy, meditative movement therapies such as Qigong yoga and Tai Chi, mindfulness-based stress reduction, defined physical therapies such as acupuncture, chiropractic adjustment, hydro and spa therapy, massage, balneotherapy, capsaicin, and homeopathy like SAMe and multi-component therapy. Pharmacologic treatments included tricyclic antidepressants like amitriptyline, anticonvulsants like pregabalin, muscle relaxants like cyclobenzaprine, SSRIs like fluoxetine, citalopram, and paroxetine, mild opioids like tramadol, which is indicated for moderate to severe pain, growth hormone, MAOIs, NSAIDs, sodium oxybate, and multi-component therapy. Current guidelines declare that strong opioids should not be used to treat fibromyalgia due to greater danger of debility. The literature demonstrates that treatment with opioids increases pain and sleep disturbance, has worse somatic symptom severity, and poorer quality of life in persons with fibromyalgia. Long-term opioid usage is associated with insufficient results in fibromyalgia patients than those who do not use opioids, and its efficacy has not been proven useful. However, long-term opioid use can cause withdrawal symptoms with discontinuance and should be weaned over several weeks rather than abruptly. Although the EULAR recommends aerobic exercise as first-line therapy, this may not always be possible. Additional research is required to ascertain whether the order in which therapy is started makes a difference in the outcome. Pharmacologic therapy is typically utilized in conjunction with the non-pharmacologic management because by the time patients seek medical attention, they have a variety of symptoms that affect their capacity to function. Although evidence-based recommendations are available, there is still disagreement over the best fibromyalgia treatment, and practitioners lack consistency in prescribing habits. Physical activity and therapeutic exercise are superior to all other fibromyalgia treatments, with supervised and graded therapy as the mainstay of treatment. According to a systematic review and meta-analysis by Sosa Reina et al. In 2017, muscle strengthening for 4 to 6 months can reduce the intensity and frequency of pain. Stretching and cardiovascular exercise can help to enhance one's physical and emotional well-being and health-related quality of life, or HRQOL. The most effective exercise programs for reducing depressive symptoms combine aerobic exercise with muscle strengthening and stretching. These regimens should be performed 45 to 60 minutes twice or thrice a week for 3 to 6 months. Additionally, the use of supervised aerobic sessions via physical therapy, muscle strengthening, and mind-body exercises for 50 to 60 minutes 2 to 3 times a week should be recommended by practitioners. The implementation of light physical activity instead of sedentary time showed improved results in physiological pain, vitality, and social functioning domains, as well as all revised fibromyalgia impact questionnaire domains. There is evidence that strength training and aerobic exercise are the most helpful in lowering pain and severity of disease, while stretching and aerobic exercise improves HRQOL. Still, combination exercise is the most effective strategy to alleviate depression symptoms. 2 or 3 low to moderate intensity physical activity sessions, each lasting 30 to 45 minutes, are most helpful. In individuals with fibromyalgia, aerobic and low moderate resistance strengthening workouts positively influence somatosensory temporal discrimination ability and clinical characteristics such as pain, fatigue, mood, and functionality, despite the performance environment. The most efficient interventions are supervised physical activity regimens incorporating low impact aerobic exercises such as cycling, walking, swimming, or water aerobics. According to Bionde et al.'s 2017 systematic review of aerobic exercise, low quality data supports pain alleviation and increased physical function, possibly leading to a slight difference in fatigue and stiffness. In contrast, moderately strong evidence supports improvements in HRQOL. The programs utilized were rather vigorous, comprising supervised exercise sessions that lasted 35 minutes on average and happened 2 to 3 times each week. Compared to healthy controls, fibromyalgia patients experience higher pain and weariness following physical exhaustion exercises requiring full body motion. Furthermore, data indicate a correlation between lower aerobic fitness levels and greater fibromyalgia severity. There seems to be a duality in fibromyalgia patients where too little activity has no advantages and too much exercise worsens symptoms. Even while these forms of exercise are typically well tolerated and have few, if any, adverse side effects, maintaining consistency is a considerable issue. Exercise regimens can be challenging to start and keep up. Patients may be concerned and believe physical activity may worsen their pain and exhaustion. Gradual increases in the volume and intensity of exercise patients can tolerate are encouraged in graded exercise programs to boost adherence. Training-induced pain and myalgias may result from aggressively implemented and advanced exercise programs, which might reduce compliance. Physical activity has some evidence showing it creates an analgesic effect and provides mental health benefits, including mood elevation and decreased stress and depression. These effects are caused by reduced N-methyl deaspartate or NMDA receptor phosphorylation, which denotes less central facilitation, a characteristic of frequent exercise, which supports pain alleviation. Additionally, frequent exercise decreases the expression of serotonin transporters, raises serotonin levels, and raises endogenous opioids in the central inhibitory pathways in the brain, suggesting exercise makes use of our natural pain relieving mechanisms. In an attempt to increase physical activity in patients, motivational interviewing aims to facilitate patient involvement in the goal of maintaining good, health centered behavior patterns and promoting adherence to short and long term exercise recommendations. However, the use of opioids hinders this approach to increasing physical activity due to its effects on motivation, cognition, mood, and energy levels, defeating the purpose of motivational interviewing. The Food and Drug Administration in the United States has approved 3 medications to treat fibromyalgia: 2 antidepressants, duloxetine and milnacipran, and an anticonvulsant, pregabalin. Pregabalin has decreased pain by 30% with a decrease in sleep disturbances and anxiety. The best results are obtained at 300 milligrams with the greatest tolerability and least risk of withdrawal. Davis et al.'s 2018 study defined and evaluated the efficacy of opioids versus pregabalin in the absence and presence of concurrent opioid use across a range of patient-reported outcomes related to pain, daily function, and exhaustion. Pregabalin alone resulted in the most significant percentage of patients reporting a 30% improvement in all pain categories and pain interference with their capacity to enjoy life, activity, mood, and sleep. In contrast, a moderate mean morphine oral equivalence dose, or MED, in opioids plus pregabalin had the lowest ranking for overall worsening relative to other treatments. This information indicates that moderate MED opioids and pregabalin maintained patients at a manageable pain level but did not improve overall pain categories. The central sensitization and mechanism for pain in fibromyalgia patients may be significantly impacted by the disruption of serotonin and norepinephrine transmission, which has been linked to endogenous pain mechanisms via the descending inhibitory pain pathways in the brain and spinal cord. The two antidepressants approved by the FDA for the use in treatment of fibromyalgia are duloxetine and milnacipran, both serotonin and norepinephrine reuptake inhibitors, or SNRIs. Milnacipran has a greater selectivity for norepinephrine over serotonin reuptake inhibition. Leon et al. In 2019 found that duloxetine was an appropriate medication for pain relief in patients with fibromyalgia compared to a placebo. The risk ratio of at least 30% pain relief was 1.31, and the risk ratio of at least 50% pain relief was 1.46. However, more significant withdrawal and side effects were noted with increased dosage. The most effective dosage with decreased adverse effects was 60 milligrams daily. According to Lee Song in 2016, milnacipran 100 milligrams and milnacipran 200 milligrams are comparable to duloxetine at 60 milligrams for fibromyalgia treatment, with no statistically significant difference in efficacy and tolerability between the medications at the recommended doses. The literature demonstrates that treatment with opioids increases pain and sleep disturbance, has worse somatic symptom severity, and poorer quality of life in people with fibromyalgia. Long-term opioid usage is associated with insufficient results in fibromyalgia patients than those who do not use opioids, and its efficacy has not been proven useful. According to the most recent recommendations, opioids shouldn't be used to treat fibromyalgia because they are often associated with more significant illness burden. Opioids are also associated with two-thirds of the United States drug overdose deaths in 2018, which decreased by 4.1% from 2017. Corresponding to the data, certain medical professionals might not be aware of the most recent fibromyalgia management recommendations listed in the guidelines. 1 in 8 fibromyalgia patients receive long-term opioid medication, according to a study looking at chronic opioids in the lower 48 states and Washington, D.C. When opioids are used frequently, fibromyalgia patients experience worse outcomes than those who do not use them, and their effectiveness has not been proven useful. Opioid users typically have a higher severity of symptoms on their fibromyalgia impact questionnaire and quality of life scores pre and post interdisciplinary fibromyalgia treatment programs. Along with all the previously mentioned negative consequences, opioid use is associated with longer sleep onset latency, decreased REM and deep sleep, and increased lighter stage sleep in middle-aged and older people. Opioids also alter sleep architecture, reducing the percentage of slow wave sleep across the board for all age groups. Slow wave sleep disruption has been associated with lower pain thresholds and increased pain perception. Fibromyalgia is supported by evidence suggesting the central opioid system is implicated, including the phenomenon known as opioid-induced hyperalgesia, which is characterized as a counterintuitive increase in pain sensitivity after exposure to opioids. However, long-term opioid use can cause withdrawal symptoms with discontinuance and should be weaned over several weeks rather than abruptly discontinued. Despite many fibromyalgia patients taking opioids, little is known about the procedure and results of chronic opioid tapering. According to Cunningham et al. 2016, the mean morphine oral equivalence dosage for most patients taking Norco was 99 milligrams daily. Individuals on less than 100 milligrams per day were weaned off over 10 days, as opposing to patients on more than 200 milligrams a day who were weaned over 28 days. At the program's end, all 5 outcome measures showed a significant improvement in numeric pain rating, depression, pain catastrophizing, health perception, interference with life, and perceived life control. There is always a chance of relapsing into opioid use. A specialist track offers the opportunity for opioid relapse education during the 3-week program. Attending these classes 6 to 8 times a week are the patients who have been identified as having the highest risk of relapsing. Additionally, a 1-day program is provided every 3 weeks, and patients are urged to attend frequently. In conclusion, fibromyalgia is a complex disease that requires tailored treatment, but physical activity should be a mainstay portion of treatment, and opioids are not a recommended primary treatment option. A special thanks to my DNP project team, Christy Crownhart, Terry Meadows, and Eric Williams. Please feel free to contact me at chanderking@isu.edu if you have any questions. And these are my resources. Thank you for taking the time to listen to my presentation, and your response is appreciated. Once again, if you have any questions, please feel free to reach out to me at chanderking@isu.edu.